Okay, so my name is Evelyn Jags, and I chose tuberculosis for my case study. The case study is of a 45-year-old immigrant, originally from the Soviet Union, with a history of tuberculosis. The man presented with fever, cough, weight loss of 15 pounds, bronchi on auscultation. Chest X-ray was positive for infiltrates. Sputum sample contained many acid-fast bacilli. 2 weeks later, his sputum culture was positive for Mycobacterium tuberculosis. He admitted to being non-compliant with his previous diagnosis of TB due to positive medications. He was started on a 6-month drug therapy. He was started on isoniazid, rifampin, pyrazinamide, ethambutol, streptomycin, and levofloxacin. He was found to be resistant to rifampin and isoniazid. The 2 drugs were discontinued, and he remained on the others. His treatment lasted 18 months. The pathophys of multi-drug resistant TB is that these resistance occur when bacteria develop the ability to withstand antibacterial attack. An entire strain of bacteria can inherit the capacity to resist. These resistance are organisms that show high levels of resistance to both isoniazid and rifampin. Just like the case study, the 45-year-old now was resistant to these 2 drugs. Resistance to isoniazid is due to the CAG or INHA genes. Resistance to rifampin is due to the RPOB gene and the beta subunit of DNA-dependent RNA polymerase. These mutations happen separately and are required in order to be considered a multi-drug resistant instead of an isolated case. Resistance to rifampin is a marker for multi-drug resistance tuberculosis in more than 90% of cases. Although it is important to consider all these facts, it is also important that we are aware that inadequate treatment or improper use of tuberculosis medications remain an important cause of drug-resistant TB. This article's emphasis was on the multi-drug resistance encountered by TB patients. Therefore, I will focus on signs and symptoms and treatment options and the pathophys. Tuberculosis, also known as TB, is caused by a bacteria called Mycobacterium tuberculosis. This infection can be fatal if not treated. It affects the lungs as well as other organs. TB is spread through the air. Signs and symptoms are productive cough, fatigue, malaise, anorexia, weight loss, fever, night sweats, chills, body ache, chest pain, and tightness. Drug therapy includes rifampin, isoniazid, ethambutol, and pyrazinamide. Add-on therapies to current drugs are beta-qualine, delamide, PA-24, linazolide, and sudafilide. In the past, 1 drug was used at a time, which proved to build up resistance quickly. Global concern is that TB is the leading cause of death due to infections. The World Health Organization conducted a survey in 1994 of 35 countries. The results were published in 1998, which found that all had cases of multi-drug resistant TB. Of course, some higher than others. The drugs for TB are limited, with no new drug classes since 1970. due to the fact that it is not a great financial incentive for drug companies, as many countries that desperately need the drug are poor countries that cannot afford these drugs. Rifampin is currently the drug of choice combined with pyrazinamide and ethambutol. Second drug of choice is isoniazid and streptomycin. Multi-drug resistant tuberculosis continues to be of concern worldwide. Therefore, close monitoring of those on these drugs are important. In critiquing this article, I found that it was a good article. The information was very informative and straight to the point. It was also an easy-to-read article. The article basically emphasized the severity of the disease and its impact globally. The information I learned by reading this article, healthcare providers have to be vigilant with sufficient follow-up to make sure that the drugs are working or that the patients are compliant, and also a careful selection of drug regimen is important. Okay, so this case study is a article review. It is of a 36-year-old male soldier presented with bloody sputum, fever, weight loss, night sweats, anorexia, cough, dyspnea, chest pain. The Montu test was 15 millimeter in size. Chest X-ray showed consolidation of the left upper lobe and cavitary lesions. Bronchoscopy showed moderate inflammation of airway mucosa. Biopsy specimen exhibit nonspecific inflammation. Bronchial washing smears were positive for acid fast bacilli. Serologic test for HIV-1 and 2 was negative. So the treatment of choice for this specific case is rifampin, isoniazid, ethambutol, and pyrazinamide. Once cultures revealed the strain of Mycobacterium tuberculosis connecting, treatment was continued with only rifampin and isoniazid. Treatment lasted for 6 months, and the patient responded positively. Okay, so the focus of this article was on the insertion sequence of the IS6110 pattern. IS or insertion sequence is a short DNA genetic coding for proteins. The genome of the membrane of the Mycobacterium tuberculosis complex has been found to have many insertion sequence elements. Now, insertion sequence can induce, duplicate, delete, and rearrange in the bacteria genome. Part of the IS family is IS6110, which was found to be inserted only in the membranes of the Mycobacterium tuberculosis complex. IS insertions elements are found exclusively within the membrane of the Mycobacterium tuberculosis complex. Because of this, it has become a great diagnostic tool. Now, IS6110 does not have a known target. The bacteria have an inability to transfer DNA. IS6110 is a multi-copy element and has up to 25 copies per genome, and it is located in different locations in the genome, which makes it easier for the strain to be genotyped. With all the advantages mentioned, there also comes disadvantages. It is said that IS-6110 may not be sensitive enough to diagnose 100% of cases. IS-6110 might also have false positive readings in patients that have had a history of TB and with cultures that are now negative following drug therapy. Now, to summarize this article, it is the fact that diseases, their DNAs, or strains can replicate or change form as evident by the discovery of this new strain of TB called Mycobacterium conneti, founded in 1969. This strain differs in that there is a difference in the biochemical test and its RNA. With the global impact of the disease, it is important that new strains are studied as they are discovered in order to avoid a catastrophe. The two patients the article mentioned lived in Africa. Therefore, it is thought that this new strain originated in Africa. In conclusion, IS-6110 has been a major breakthrough in the diagnosis of TB, especially this specific strain. IS-6110 has the inability to exchange DNA, which is why they are widely used markers in epidemiological studies, as well as major diagnostic tool for tuberculosis. In critiquing this article, the only thing I found was that because IS-6110 played such an important role in diagnosis, the author should have defined and explain the usefulness, structure, organisms, and functions of IS-6110, which would have been very helpful. Other than that, the article was very informative, and I learned a lot. This case study is a review article, and the case study is of a 22-year-old college student who presented with recurrent fever, loss of appetite. He was found to be irritable, which was stated that the irritability started occurring about 4 days prior to his admission. He was pale, GCS of 12. His loss of appetite resulted in severe weight loss. He also presented with signs of meningeal irritation, right sixth nerve palsy, resting hand tremors, generalized rigidity. Cognition problems were also noted, such as apathy, psychomotor retardation, and loss of memory. His laboratory studies showed a reduction in hemoglobin, elevated ESR, HIV-1 and 2 was negative. Lumbar puncture was also done, which is considered the gold standard for diagnosis, which revealed elevated protein and low glucose. About 80% of diagnosis for this condition is done through lumbar puncture. Chest X-ray showed bilateral diffuse infiltrates. MRI showed mild dilated ventricles with lesions along the convexity sulci, which suggests chronic tuberculosis meningitis. The patient was then started on Category 1 intensive phase medication, such as isoniazid, rifampin, pyrazinamide, and ethambutol, along with parenteral dexamethasone and also mannitol for intracranial pressure. In summarizing this article, Tuberculosis meningitis starts in the lung, as with any other TB, via inhalation. Bacteria then spreads over 2 to 4 weeks to the lymph nodes, and then spread to the meninges or the brain via hematogenous spread. Once the infection reaches the brain, they can remain dormant for years. The infection can reactivate due to decrease in the immune system. The author gave a detailed information on tuberculosis, meningitis. They touched upon the disease process, diagnostic tools, treatment options, and even prognosis. The emphasis was on these rare symptoms and prompt diagnosis and treatment. It is important to note that mortality rate is 20 to 30%, but in this case, the patient made a full recovery and was discharged after 14 days. Critiquing this article was fairly easy. I found this article easy to read. The important points were touched with an emphasis on these rare symptoms that can mimic any other disease. In order for them to be recognized for what they are, in order to prevent a delay in care, TB remains the leading cause of mortality and morbidity worldwide. This case study is of a 44-year-old white male presented with fever, fatigue, breathlessness. Biopsy was positive for alcoholic cirrhosis. Acid-fast bacilli samples were negative. Culture was positive for Mycobacterium tuberculosis after 12 days. He was HIV negative, but he did die 44 days after his admission. Mycobacterial interspersed repetitive unit variable number tandem is an important method used to investigate specific genotypes. MIRU DNTR allows discriminatory and reproducible analysis of isolates. This reliable typing permits easy identification of local and international outbreaks. This method has proven to be a reliable genotyping of Mycobacterium tuberculosis and is considered a more superior method than that of IS-6110, which was once considered the gold standard for the study of TB. MIRU VNTR is now recommended to be the standard internationally. There is 16 to 24 loci, which is the specific location of a gene, DNA sequence, or position on a chromosome, and with up to 24 markers, which facilitates prompt, reliable identification of situations involving potential outbreak cases, mixed infections, or reinfections. In this case, 36 South African strains were compared for each sequence strain. A random subset of reads was aligned to generate a list of single nucleotide polymorphisms and insertion and deletion. Pairwise comparison of whole genome sequences from Mycobacterium TB isolated from patient 1 and 2 found 2 sequences differed at only 4 single nucleotide polymorphisms. With estimating background mutation rates, it was found that both patients' transmission was about 4 years. There were also differences of 69 to 72 single nucleotide polymorphisms, which proved that transmission was not between these patients. Therefore, nosocomial infection was not the factor. To summarize this article, MIRU-GNTR stands for mycobacterial interpersonal repetitive unit variable number tandem repeat, which is a testing method used to investigate specific genotypes of TB. The specific strain was found in a 44-year-old white HIV-negative male. That same strain was also found in a 42-year-old HIV-positive healthcare worker. It was established that both patients had some form of contact at some point. Both patients were admitted to the same medical ward in 2008 for 8 days. The ward was a traditional Nightingale setup with beds for males and female patients arranged in a dormitory style. Patient 2, the 42-year-old, who was later discovered to have had pulmonary TB, was managed on an open ward without the proper isolation, therefore exposing all the other patients. In 2009, when patient 1 was found to have had this exposure to patient 2, he was offered screening for latent TB infection, which he failed to follow up. A pairwise comparison of whole genome sequence from mycobacterial tuberculosis isolates the two patients that the two sequences differed at only 4 single nucleotide polymorphism. Transmission was determined for both of them for at least 4 years. Further comparison was done between what the article referred to as patient 1 and 2 versus patient 3 and 4, which found 69 to 72 single nucleotide polymorphism differences. That argument of a nosocomial infection was proven to be negative. Isolates for patient 1 and 2 were found to be related to another outbreak called the Tugela Ferry outbreak, and isolates from patient 3 and 4 were outbreaks that resembled those around that particular region. Nosocomial infection was subsequently ruled out from these cases, but the author suggests that increased vigilance for TB with proper screening among healthcare workers and others is required. In critiquing this article, I found that the article was a little vague. I would have liked to know a little more about all the patients, especially patient number 2. Other than the mere mention of a 3rd and 4th patient, the cases were never presented. MIRU-GNTR, which stands for mycobacterial interpersonal repetitive unit variable number tandem repeat testing, was not described in detail. The article lacked key facts about whole genome sequences of pathogens, such as what it is, and more details of how it's done. Overall, I find this article to be informative, but not thorough enough, and this article is a reviewed article. This case study is of a 35-year-old female prisoner presented with fever, 22-pound weight loss, wasting syndrome, thrush, purulent cervicitis. Chest X-ray was positive for right hilar adenopathy. Lab results were hemoglobin of 10.8, WBC 2900, serum albumin 2.9. Urinalysis showed WBC of 25, red blood cell of 10. Urine specimen was positive for chlamydia and gonorrhea. HIV antibody test was positive with a CD4 count of 27. The patient was placed on a regimen of 5 drugs: isoniazid, pyrazinamide, rifampin, ethambutol, and ofloxacin. After After 1 week, the patient was found to be resistant to isoniazid and rifampin, and her regimen was changed. She was also treated with antibiotics such as ceftriaxone and azithromycin under strict direct observation therapy. With her age confirmation and a CD4 of 27, she should be started on a heart therapy, which is a highly active retroviral therapy. But that was held for the first 2 months after TB therapy was started to decrease the risk of adverse effects. In this case, the patient presented with latent Mycobacterium tuberculosis, which means the patient is infected with TB, but the patient does not have active tuberculosis. The presentation of tuberculosis in an HIV-infected person can be different. Radiographic studies are often atypical and may not demonstrate classic findings. Secondary tuberculosis or latent TB arises in a previously sensitized host. It may occur shortly after an acute infection or possibly decades after the initial infection, which is an example. In this case, the patient's initial TB presentation was 10 years prior. Reactivation of dormant infection usually occur when a host is weak. In this case also, the host immune system is definitely weak, with positive cultures for chlamydia and gonorrhea and multiple abnormal labs. Patients with CD4 count of greater than 300 usually present with usual secondary tuberculosis signs, whereas patients with CD4 count less than 200 usually present with atypical presentation, such as lower middle lobe consolidation, Hiller lymphadenopathy, as evidenced also with this patient presenting with right Hiller adenopathy. Remember, TB bacteria are spread only from person to person with active TB disease. Latent tuberculosis is usually not contagious, but the person should remain alert to symptoms of active tuberculosis for a lifetime, even after completing the course of medications. Therefore, the identification and treatment of people with latent TB is an important part of controlling this disease. Prevention is key, as with any other disease. To summarize this article, this 35-year-old woman presenting with fever wasting syndrome, but with none of the typical signs of TB. She was negative for cough, nausea, emesis, headache, diarrhea, skin rash. Her chest X-ray showed atypical signs, such as right Hiller adenopathy. But with several bouts of TB within the last 10 years, she's determined to have latent TB. This woman is also positive for other serious ailments, such as chlamydia, gonorrhea, HIV positive with a CD4 count of 27, meaning she has progressed to AIDS with a very low CD4 count. Many of the labs were abnormal, and she admits to being non-compliant. Therefore, she needed direct observation therapy to ensure compliance. The article emphasized on MDRS, multi-drug resistant tuberculosis. As with this case, her regimen had to be changed after she demonstrated resistance. The author went on to describing the difficulties of being HIV positive plus infected with TB with a treatment plan of possible 20 pills daily, and some of the physical symptoms associated, like peripheral neuropathy, rash, and gastrointestinal upset. It is important to know that treatment outcomes vary among patients. Responsiveness depends on the extent of pulmonary involvement, numbers of bactericidal drugs used, and the patient's ability to comply and tolerate therapy. And of course, a very strong community resource needs to be available. In critiquing this article, I find that this article was very informative. The article started with the case study and detailed symptoms of the patient and progressed to describing latent TB, also MDRS, which is multi-drug resistant TB, as presented with this case. I do think for better understanding, the symptoms could have been explained in more detail, especially chlamydia and gonorrhea being a sexually transmitted disease, and also what a CD4 count of 27 means. The meaning of her lab studies could have been also described in better detail. Overall, the article succeeded its purpose, presentation of this case and the challenges with HIV patients with TB, and initiation of direct observation therapy as a way to ensure compliance. This was a reviewed article.